Good afternoon, everyone, and welcome to today's COVID-19 planning webinar. We're really pleased to be doing these webinars twice a week to bring information to our workforce that's streaming to us through the staff email line and on other means. It's an opportunity to answer the questions that are coming up in those forums and to talk a little bit about what's going on across the organization as we plan together in response to the COVID-19 pandemic. Today, I'm joined by a number of colleagues who will be contributing to today's webinar. I'm joined by our President and CEO, Rob McIsaac, our Medical Director of Infection Prevention and Control, Dr. Dominic Hertz, our Executive Vice President, Clinical Operations and Chief Operating Officer, Dr. Wes Stephen, our VP of Quality and Performance and Chief Nursing Executive, Kirsten Krall, and our Vice President of Human Resources, Michelle LaRue. So we'll get started right away. I guess, Rob, I'll go to you first for the news of the week, the news of the day. Can you tell us a little bit about what's happening in terms of our planning right now and what we're going to see in the days
ahead? Yeah, sure. Thanks, Aaron. So today I'd like to talk a bit about just our local context and the capacity work that's underway, touch on PPE, talk a little bit about screening, and we'll finish today on communications. We think about what's happening in the country. There has been a lot of modeling that's gone on, and so I think Canada can take some solace in the numbers that, frankly, we are not seeing the kind of increases that some other countries have had. But having said that, I think we need to be prepared for a significant situation here in Canada and Ontario. We've had about 8,500 cases in the country, and so you can see that that's up by about 1,300 cases since yesterday. So we are seeing some steep increases as a percentage. We've seen about 96 deaths. Again, I think that's probably a bit better than what some other countries have seen. For us in the province, about 3,200 cases, again up 450 cases since yesterday, and about 67 deaths. So, we are continuing to plan based on the work that we've done, which I think is kind of a worst case scenario. We are hoping for better than that. We're hoping that the social or physical distancing measures that have been implemented will help to moderate the impact of the virus here in Ontario. For us locally, we've been doing some extensive modeling and scenario planning, and I think HHS can be really proud of the work that our staff has done in creating a model and adapting it to local conditions to try to give us the best possible estimate of what we might be in for. We're getting ready for a local surge. We're finalizing our plans based on those models to ensure that we've done everything we can to have the space and the resources available to care for COVID-19 patients as the virus starts to really take hold in the community. This includes relocating some of our patients into the community where we think it's appropriate for that to happen. So if we think the community has the wherewithal to responsibly look after these patients, we are moving them into the community wherever we can. We're also preparing unconventional and currently inactive hospital areas for patient care. We're working closely with regional partners. HHS is kind of a hub for hospitals across Niagara, Hamilton, Burlington, Brantford, and beyond. So think it's really important that we understand that we're part of a larger region, that if our neighbors get overwhelmed with cases, that will ultimately end up here at HHS. So it's important that as we do our planning, we understand that we're part of a bigger system and that we're working with those regional partners. I might just talk a bit about PPE. There's lots of anxiety on this topic across all of HHS. I totally understand this. It's probably worth stepping back just for a minute and saying, hey, we are HHS, the guidelines we have in place for PPE are in alignment with the provincial directives that have been issued by Ontario's Chief Medical Officer of Health. We are continuing to gradually extend the use of PPE at HHS, and we're doing that having regard to the level of supply that we have of PPE, but also having regard to the level of risk that different areas of the hospital are seeing, and trying to strike the right balance between those two. PPE continues to be a very precious resource on a global scale, and we are doing everything we can, working literally day and night, trying to get more supply into HHS to ease the concerns around our inventories. We're doing our best to strike a balance between managing risk and responsibly preserving what is unfortunately a very limited supply of personal protective equipment. It's an incredibly difficult situation to be in, and I just want to thank our staff and physicians for their understanding and patience on this matter. This week we launched a new screening process for staff and physicians across our sites, including a new screening app. We think this tool will create a smoother screening process for everybody coming into our hospitals and help us with workforce planning. As with any new initiative, particularly an initiative that was designed so quickly because of this crisis has come on so quickly, there have been a couple of bumps along the way. I want to say thanks to everybody for their patience and understanding. We will continue to iron out any wrinkles to try to make this as smooth and easy for people as possible, so that when you come to work, you're not being unduly delayed. I just ask everybody to please keep using the tool, and if you need more information, it is available on the hub. As always, I just ask everybody to stay tuned to the latest information on email, the hub, and social media. I know it must feel like a lot of information coming at you, and we're doing our best to streamline it. We'll continue on with those efforts so that we're not bombarding you with information. We'll try to keep it as organized and succinct as possible and as user-friendly as possible. And of course, I'll just finish by extending my gratitude to everybody for all of the work that they're doing, which is so important for this community. So thank you. Aaron, back to you.
Thanks very much, Rob. So next I want to go to Dr. Dominic Mertz. Dominic, I'd like to kind of level set the rest of our conversation with a question to you about where we're at locally. What are the numbers looking like in Hamilton? Is there any evidence yet that physical distancing or containment is impacting our curve here?
Thanks, Aaron. So as you can see on the slide, we are sitting as per today on 138 confirmed positive cases within the city of Hamilton. Roughly 10% of cases were hospitalized at some point and 2 deaths so far. But in terms of flattening the curve, when I'm looking at what happened over the last few weeks, there's only so far 7 cases that are attributed to the current calendar week. So that's a small number, but always keep in mind that the last point in the time series isn't reliable, because we will have cases that come up next week that became symptomatic this week. Looking back in the week 12, so 2 weeks ago, we were at 95. So not a lot has changed over the last couple of weeks in terms of number of cases that are known in Hamilton. So it looks like a relatively flat curve in Hamilton. And as I said previously, it looks like we are lagging behind other areas. And I really hope that we continue to do so.
As you know, as Rob said, we're hoping for the best, planning for the worst. I guess as the community incidence increases, like what's that mean for the risk level at our sites? Can you talk a bit about that?
I mean, reality is if and when transmission in the community increases, it increases everyone's risk, whether you work in a hospital or outside of the hospital. So it increases the risk of patients bringing it in. It will increase the risk of healthcare worker bringing it to your workplace. So there will be an increase in risk regardless of the area you're working in. As long as you can use the PPE appropriately, I don't expect that you are at higher risk only because you may see more COVID-19 patients. But it's a community transmission, it's a public health crisis, and we cannot protect ourselves entirely from that in a healthcare setting.
Thanks very much. Dr. West Stephen, I'd like to go to you next. I think given the reflection of data that Rob talked about and that Dominic has spoken on, you know, what is, as we think about a surge in Hamilton and our position as the region's largest hospital, how are we preparing for this surge, thinking about the role that we're going to need to play? Maybe you could talk about what's ahead and how are we doing right now?
Thanks, Aaron. As already alluded to, there has been significant modeling, which is really a best guess of how much demand or how much burden of disease we will have in our community based on our population and learning from other jurisdictions internationally and nationally. We get a better sense of what we think is the number of patients who will require admission to hospital, how many will require admission to an intensive care unit and to be placed on a ventilator. Understanding this allows us or guides us in our capacity management or our ability to plan for the number of beds, staff, and equipment that will be required to manage COVID-19. We have taken an approach of stages of where we are looking for ability to find that capacity. So the waves of escalation of the work that has been undergone by our teams is the first one area that there's been significant work is on the ramping down of non-essential services and scheduled procedures. To date, we've had significant reduction of our ambulatory care activity. With excluding our cancer center, we only have 17% remaining on site patients coming for ambulatory visits. We have converted 35% of those patients to virtual care and 42% have been deferred. By decreasing the ambulatory traffic, we are in hopes of to decrease the spread of the virus within our building and to our staff and to other patients, as well as to build capacity from a physical point of view and allow some redeployment of our staff. Over the next several weeks, as we start to temporarily close some of these clinics, the organization will start to see this in a much more visible way. Another area of significant activity over the last several weeks has been to really defer scheduled care, particularly in interventions and our perioperative program. To date, we've exceeded over 50% reduction across the board of our organization. Once again, this builds capacity from inpatient beds, as well as allowing for increasing of our staff complement to be redeployed into areas that will be required for COVID. We've had over a 40% reduction of diagnostic and imaging, And as a result of this reduced scheduled care, and interestingly, a decreased demand from the emergency department over the last several weeks, we have built a capacity of over 300 beds in Hamilton Health Sciences. This is extremely impressive for a capacity that we have just from these activities.
That is an impressive number. So hundreds of beds available at this present time. I mean, if we look ahead and think about the numbers that are being released even today by the province, what would we do? Like, what are the plans in place if we exceed that available space? What comes next?
Yeah, thanks, Aaron. In a very proactive way, we have started a decanting process of patients who are most eligible or are eligible to be in the community, and we have actually looked for both conventional and unconventional spaces to place particularly rehab-like patients or our ALC population. Part of this work is to increase placements within the community, and working with our partners, we've been starting to see some success in getting ALC patients in conventional spaces in the community. As well, in less conventional spaces, we have gone out and looked at various organizations or areas in the community to look for that space. And I would say that we are in active negotiation with one of the local hotels in looking at placement of patients who no longer need acute care and that could be safely placed in a hotel room with our staff. On top of our decanting strategy is also trying to avoid patients being transferred to our hospital, and we're quite happy that we will be in the process of launching virtual care, which is a 24/7 long-term care line for all Hamilton patients in long-term care that can connect virtually to consultants through this. This is a joint effort with St. Joseph's Hospital and ourselves.
Thanks, Wes. I want to talk a bit more about PPE and the Chief Medical Officer Health Directive that was released recently. Kirsten Kroll, if I could ask you, can you explain a bit about that directive from the CMOH, or Chief Medical Officer of Health of Ontario? How does that impact us at HHS?
Thank you, Aaron. So the guidelines or the directive is really very congruent with what we're already doing at HHS. So of course, the COVID patient would still always be managed as a droplet and contact precautions. And if there's aerosol generating medical procedures, again, another spray or so on from the airway, people would then continue to don their N95 masks. For those higher risk procedures. The directive did describe in a little bit more detail around what is considered what's called an AGMP, the aerosol generating procedures. And some of those were a little bit different than what we had seen before. So as an example, an intubated patient is now included in that list. We had up until then already had our critical care nurses, our primary nurses in the room with patients wearing those N95s anyways, if there was concern around a disconnect of the tube. So here we have in the new directive an expectation that the N95 would be worn. So that's all very congruent. Still, we want, ultimately this always comes down to using good clinical judgment, and again, using what they call in that document, and we're going to adopt as that point of care risk assessment. So again, not unlike what we already have in all of our infection control protocols, that are certain features that you're looking for in your assessment, not only with the patient, but also the environment that you're going in. So that judgment needs to be respected, and certainly that's coming out of the directive as well. So nobody would be unreasonably denied an N95, but again, we always need to make sure, and the Chief Medical Officer reiterated that, the disease is always continued to be treated as a droplet contact precaution, but use your good clinical judgment in the selection of your PPE. So we're following the directive, and meetings with ONA have been occurring in a variety of different ways, but they will continue to be carried on, and we will talk more about the plan that we have for our PPE.
And we've talked previously about taking a phased approach, looking at risk to PPE that would see us gradually escalate as we move forward. Can you talk, like, what does that look like over time, and where are we at right now?
Yes, so we are in phase 2 right now, which means what we're doing is making sure that we think about what's called universal masking in certain areas where that risk might be getting a little higher. So as an example, you folks might be familiar with the advice that we provided a few days ago around certainly the emerge department doing kind of much more masking right from the day that, or from the time that they enter the shift, and the care of their patients. We extended that also to critical care, and there will be some other areas that are coming on board as well, such as our COVID medicine units that have been identified to receive those patients when they hit a certain threshold, which is what happened at Jurabinsky this week with 4 patients. At that point in time, we moved them to what's called universal masking. So again, it's really a way to try and help contain transmission, and again, making sure that it's not only about having the mask on the staff member to protect them from the patient, but also if there's any risk that might be happening, pardon me, with some of that exposure, to make sure that they're not spreading things between each other as well. So higher risk areas are going to move to this, and we've just in the process this week spread that to the neonatal units, but also recognizing for neonatal, again, wearing their PPE out to a unit when they're taking a baby to the floor, coming back, that mask is still something that they would continue to wear as part of the conservation strategy. Other areas are coming on board where, again, they've got more public-facing kind of interactions that are still fairly frequent. Patients that have a longer duration with us, even in that ambulatory visit. So, and as an example, a patient going to interventional radiology is a good example. Even our children's dialysis program, again, those are individual areas where we believe, again, we're just going to take that step up, get to universal masking. In other words, you start wearing a mask for the day, you leave it on as much as you can. And we know in some cases people need to do surgical procedures with a surgical setup. But again, coming out of that environment, you've got your mask on, trying to leave it on for the course of the day. To protect people. Yeah, so that's where we're at this point. So that list is expanding a little bit. We'll start to include the cancer center, the HIU will start to be included. So our educators are out there starting to get those areas ready. When we get to level 3, we're not there yet, but eventually starting to spread to other clinical areas. So the inpatient units and so on. The wards, as an example, where they really don't have any COVID exposure to any significant level at this point, and certainly we're very mindful of what's happening in the community activity, and that's why it's important to listen to Dominic's discussion around the level of risk. So we need to gauge that, but we also need to be very mindful of our PPE supply, which is certainly impacting the decisions around where we head with these expansion of the universal masking. So as an example, we heard today that from the US, their administration there had indicated that 3M won't be allowed to ship outside of the US. So that will mean Canada does not get 3M shipments. So again, we can tell that that PPE supply chain is very, very precarious. So we absolutely need to make sure that we continue with our conservation strategies.
Thanks very much. An evolving and critical issue for sure. I know a lot of work is being spent working on procurement and moving us through these phases. Thanks for the explanation you've provided. Michelle Leroux, I'd like to go to you next. There's been a lot from your team this week. I know everyone's been super busy. As Rob pointed out, we have launched a new mandatory self-screening tool. There's been some feedback. We're working really hard to tweak that process and think about how to make it flawless. Can you tell us a little bit about that and remind everyone exactly what was the intent in launching this particular tool?
Thanks, Aaron. Yes, this is part of our commitment to the safe and healthy workplace for our patient, staff, and physician. It's a great tool in that it allows us to take our current standards as they change. So when we get revised criteria for our healthcare workers for the testing of them, we can adjust it in this tool, which allows us to stay current quickly. You know, yesterday was our first day, and not our full first day, just kind of our tester day. And we had over 6,000 employees complete the online assessment tool, with 98% being cleared to proceed to work. Honestly, that's an excellent response. I think we should be very thankful to our staff and physicians who've made this a priority, who are utilizing the technology, who are clearly committed to keep everybody safe at HHS.
That's an amazing number. So I guess I want to go to my next question around the tool in particular. Like, can you explain a bit, like, what have we learned so far in that rollout? And maybe just talk a bit, like, what is the process? What does the screening process look like for those that haven't gone through it?
For sure. So ideally, when you're at home, before you go on to the link and you complete the tool. It takes less than 2 minutes. Done it myself frequently, obviously. And then when you get to your site, you show that tool at the screening booth. The flow has been good at the doors, definitely room for improvement as we work through the process, but it's only been one day. So I think overall it's going well. People seem to really like using the QR code. So the posters at the door, you just hold up your phone and screen it. You know, the things we've learned, our staff and physicians give us our best hints and tips. So for example, don't forget we have free Wi-Fi. So we want you to do it at home, but if you can't, then we've got the free Wi-Fi at the sites where you can go on and log on and use the tool. Also, if you, when you do it at home, if you don't want to use your data or you don't want to wait to get to the hospital to use the Wi-Fi, just take a screenshot of what you completed at home and then show your phone when you walk in the door. Don't forget to bookmark it, right? It's your link you need every day before you come into work. And we've got this and many other things on our hub story that went out, I think, just yesterday or today, actually, that has a number of tips that we can use. And we continue, like the team running this screening is very committed to make this as efficient as we can for our staff and physicians. So we've got fast track lines at some of our larger sites. We've got our contractors and our non-HHS staff using a different process, still ensuring they're screening, but going a different way so that we're not holding up our line.
It's an amazing project. It's a big thing to get up and running. So thank you for that work and for that update. I want to talk a bit about redeployment as well. That seems to be ramping up, and I know it's important work. Can you talk about, you know, what does this look? Why is this so important? And what are we doing to implement a redeployment process at HHS? What can people expect to see next?
Thanks, Aaron. Yeah, redeployment is near and dear to my heart, definitely. We know that the weeks ahead will become more challenging, and we need our staff and our physicians to be focused on being able to provide the best care we can to our patients, which means using our workforce effectively. Just yesterday, we launched a leader tool that helps our leaders across the organization help identify our staff that can be redeployed. That's just one aspect in a very detailed process of how we'll move forward. You know, we need everyone across all of our clinical and non-clinical areas to really assess their work and make sure, you know, how are we doing things? Can we do it? How can we do things differently to maximize the number of staff we have to be able to be redeployed to the areas who will really need it over the upcoming weeks? You know, there's postings up, so please tell your family and friends who might be interested in joining us to help out in this very difficult time. We've got RN postings up, RPN postings up, lots of different healthcare aides. There's more coming. So definitely go to the website and keep an eye out. We've got quite a few strategies in place. We've got some great retirees who want to come back and help us out. So quite a community outreach, and we're thankful for that.
And maybe one last question for you, Michelle. I know there was some good news this week around parking, in particular parking fees for staff. Can you tell us what that news is?
Yes, it seems to be the hot topic, Aaron. Everybody is very happy to hear that for the month of April, there will be free parking. So for our staff, no deductions off your pay. For our wonderful workforce that's being redeployed to locations, no worries about going from, you know, Mumsy to the general. So it's been a really great news story and really well received.
So if I have a transponder, I wouldn't be billed this month. Is that the process?
That is true. You will not be billed this month.
Oh, okay. Well, thank you for that update. And thank you to all our presenters. I'm conscious of time. I really appreciate all of you who have tuned in to listen to this podcast. I guess it's recorded and posted on the hub, so you can circulate it, please, to others that you think would benefit from this information. It's the topics we're talking about are based around what is certainly happening right now, but also what we're getting most questions about through the staff email line. You can use that email line to pose questions to us, make suggestions about topics, about communication, about what you're seeing in the organization. Please do stay in touch through the hub. Download the app. I'm really proud to say that we're at almost 4,000 subscribers to the app now across our organization. We've heard from many people that it's a great way to keep on top of the latest news around our COVID-19 pandemic planning. We will be back with another broadcast for you next Tuesday. Until then, please keep safe.